Good afternoon, everyone, and thank you so much for joining us. We are just letting everyone in the rooms, coming in from the waiting room, but we will get started immediately. So thank you so much for joining us. Barb, you want to go ahead and start?
Oh, sure. So hello and welcome. I am Barbara DiStefano, a member of the Junior League of Orange County. The renewed focus on racial inequity in the U.S. justice system led active members of the Junior League to have a conversation about systemic racism and implicit bias. In order to educate ourselves and provide the community a lens into systemic racism and implicit bias in healthcare specifically, we partnered with the Orange County Human Rights Commission to present this virtual panel discussion. We are looking forward to hearing these community leaders share their expertise on the challenges in access to healthcare, social determinants of health, and health disparities. It's my pleasure to introduce Einaudi Esposito, Executive Director of the Orange County Human Rights Commission, who is an avid advocate and voice for targeted and oppressed communities. Einaudi will serve as the moderator for today's panel discussion. So Einaudi, I turn it over to you.
Thank you so much, Barbara. And again, welcome everyone. I am Einaudi Esposito, the Executive Director for the Orange County Human Rights Commission. And like always, we are, as a commission, committed to making sure that we are engaging partners and bringing really vital information into our community around issues that are impacting the most vulnerable of our neighbors and family members. We are really excited to be partnering with the Orange County, or Junior League of Orange County, but we are really also excited about welcoming our incredible panelists to this really wonderful conversation around health disparities and inequity. Just some housekeeping things before I introduce our three panelists. We are asking if everyone can please turn your cameras off. It'll make it nice and smooth while we're recording, and it'll make it easier on you, so the pressure is off of you. See how quickly everybody turns their camera off? And then we're also asking everyone to just keep your phones on mute. We will have an opportunity for chat later on, so we will allow everyone to include their questions in the chat. So please, throughout the entire program, if you have any questions whatsoever, feel free to enter them in the chat. We will be monitoring it. The way it will work is we will start with a short presentation and overview of the challenges that we're going to be talking about, and then we're going to open it up for the panel to go through some questions that we have prepared. And then the last 20 minutes of the program, we will be opening it up to you. So as you think of a question, please enter it in the chat box, or if you want to wait until the end, that's completely okay as well. But we really hope that you were all engaged. So to get us started, I'd like to welcome Michelle Mckeon, COO of RECAP right here locally, and she will get us started in talking about health disparities and what does that look like and helping us define it. And when she's done, I'll introduce the other panelists. Michelle?
Thank you, Einaudi. I am sharing my screen, so hold on one second. Okay. And I'm just trying to get it to full view. Sorry, the toolbar is barring my ability to give it full view. So I'm now just trying to play around with it.
That happens to me often, actually.
Mm-hmm. All right. So hang on one second. I'm just trying to move the toolbar out of the way. Okay, that should not take from my time, Einaudi. That was a technical difficulty.
I'm going to hold you to
I am very excited to present the kind of foundations of the social determinants of health. It's a 2-hour presentation that I have 11 minutes to go through. So I apologize already for talking too fast, but please put your questions in the chat and we'll be able to go ahead and answer them as we go. So as we think about the social determinants of health, we have to think about what poverty is, and that we have to recognize through this quote that it is not an accident, and it's like slavery and apartheid, it is man-made and can be removed by the actions of human beings, and we are the human beings. So when you think about your lived experience, who has lived experience in poverty? And by lived experience, do you know somebody who's lived in poverty, or have you yourself lived in poverty? And when I say the word poverty, as the Anti-Poverty Agency, we're really talking about these numbers. And I know a number of you have a really good handle on poverty and social determinants of health. And in many cases, I'm preaching to the choir, but even the choir needs to practice, right? So this is what you need to pay attention to and think about your own family. And if you are a family of 4, if your annual income is $24,300, what does that limit you? What does that get you? Think about your expenses. Do you have enough for a cell phone or a birthday party? And how does your life differ than from somebody who may live at that 24,300 level? And when we look at the official definitions of poverty, it seems like a no-brainer. It's people with less income than deemed sufficient to purchase basic needs, food, shelter, clothing. They are designated as poor. The state of one who lacks usually or socially acceptable, who's socially acceptable is in measurement is of question, amount of money or material possessions, and it's a state or condition in which a person or community lacks the financial resources and essentials. How I define poverty, it's a chronic and debilitating condition that results from multiple adverse synergistic risk factors and affects the mind, the body, and the soul. So if we are just treating a one spoke of a poverty wheel, then we are not treating the entire person. There are 6 types of poverty. It's situational, generational, absolute, relative, urban, and rural. And the definitions are next to them. But if you are sitting in the city of Newburgh, your definition of poverty may be different than the town of or village of Goshen, where I used to live. I now live in the city of Newburgh. And as we look at our beautiful county, this is certainly part of what our county is. It's beautiful. We have waterfront, we have hills, we have mountains, we have vistas. But this is also part of our county and our county's narrative. This is not just one area of our county. These pictures are taken from numerous cities and villages and towns throughout our county. And the health of an individual is almost inseparable from the health of the larger community, and the health of the community and territory determines the overall status of a nation. So the social determinants of health are not just genetic or biological, it's influenced by the social conditions. Where do you live? How do you live? What's around you where you live? And that is what's known as the social determinants. And there are 6 focus areas: economics, environments, food, social, healthcare, and education. And then you have the associated categories in each of those focus areas. And they are access to those things. So you can have the amazing Cornerstone Family Health Center, which is my primary care, and it's where I get my health care. It's my health home. Does everybody have access to Cornerstone? And in my experience, yes, it's where we send our clients as well. Do they have access to resources? What is the educational system? What kind of segregation is there in your community? Do all people who live below the poverty line live in one area, and do people who have means live in another area? And something we hear in every single one of RECAP's needs assessment is, what does our transportation look like? And we cannot not speak about food apartheid. Food apartheid used to be known as food deserts, but food apartheid is also man-made. So we want to talk about that a little bit more. And this illustration really looks at what you cultivate really determines your outcome. So if you cultivate inequity, you see what happens to our beautiful tree, right? It is is woeful, and it is sick, and it is not healthy. But when you look at inequities, and inequities are low throughout a community for all of the associated factors, you have a much healthier tree with all of the same issues, but you have resources that create the ability to address those things and help increase good health outcomes. So risk factors for social determinants of health are abandoned buildings. What are in those buildings? Is it asbestos? Is it lead? Is it fall through to basements? We look at this train crash in the city of Newburgh, and we talk about environmental racism. There is that was almost a catastrophe in our city, and the fact that it happens in an urban area, in an area with communities of color, rather than, again, my old village of Goshen, is a conversation that we don't have enough. And again, looking at the state of our water. Is it clean? Is it healthy? Is it drinkable? We talked a little bit about food deserts or food apartheid. In the city of Newburgh, there are no walkable grocery stores. There are plenty of bodegas, but not good, healthy, affordable food. And of course, we look in each community about the significant health factor of community safety. And there are three overarching factors: economic inequality, social connectedness, how connected are the communities to one another, and a sense of efficacy, our belief that we can succeed despite our challenges. And the way those three overarching factors play out is differences in exposure, our differences in vulnerabilities, and the consequences for different populations. As we level set, we really need to understand that race and gender, ethnicity, sexual orientation, gender identity play a factor in those consequences for different populations. So what's the big deal? Why does it matter? Well, an individual who lives in the village or town of Warwick will live to almost 84 years old. And an individual who lives in the city of Newburgh will live to 74 years old. That's why your zip code matters. So when you have good health status, you have parks and sidewalks and grocery stores and banks, better performing schools, good public transportation, and that gives you a good health outcome. When you are looking at communities with low income, it's fast food restaurants and liquor stores, unsafe or limited parks, increased pollution and toxic waste site, and limited public transportation. And that relates to public health status. It contributes to disparities, obesity, diabetes, asthma, and infant mortality. And equity is the only acceptable goal. So how do we create not equality, but equity in our healthcare? And healthcare manifests themselves in race, gender, ethnicity, your social class, your nationality, your language, your legal status, sexual orientation, disability, geography, and religion. And these are risk markers, not risk factors. And that's really important to say. I know Cornerstone serves everybody. Not every health institution does that. So they are actively working towards equity, rather than highlighting inequities. So when we look at the broader issue of social determinants, we look at environment, biology, and what the social factors are. So if we look at the environment, urban crowding, toxic agents, physical agents, and that's what we talked about, air pollution, water pollution, housing quality. What does your housing stock look like? What is your working environments? What is the quality of your neighborhood in general? Do you have fewer parks? Do we have buildings with lead paint and mold? Do we have less funding for our schools? And crime is a factor when it's less ability to go outside without concern. You have an increased chance of being a victim of crime. And then we have stop and frisk and higher levels of incarceration. And when we look at the biology, we look at genetic and behavioral and lifestyle. And we have elevated death rates for poor are evident in almost all of the major causes of death, including infectious, nutritional, cardiovascular, injury, metabolic, and cancers. And if we look at this graph right here, those without a high school diploma are 3 times more likely to smoke and 3 times as likely not to engage in leisure time physical activity. And when we look at the education level across the board, with green being less education and dark blue, navy blue being the highest, you can see very clearly the differences of your instances of high blood pressure, poor glucose regulation, meaning diabetes, and inflammation. So again, that is part of your biology. And when we talk about access to primary care, hospital services, FQHCs, we really need to very clearly talk about what's going on with COVID. There is a lack of access to care for Black and Brown communities, lack of access to vaccines for Black and Brown communities. How do we create equity for those communities when we're talking about a global pandemic and they're already challenging access to good quality healthcare? Inadequate healthcare may account for 10% of premature deaths, and healthcare receives by far the greatest share of resources and attention. And usually when we're talking about healthcare, we're talking about hospital systems, not necessarily our FQHC. Preventative care is really important. So we have to really highlight, in particular for Black and Brown women, mammograms, pap smears. You know, how many places in the city of Newburgh, the city of Middletown have mammography capability? How many of those do nighttime or weekend appointments for access purposes? Common diseases have roots in lifestyle, social factors, and environment, and successful health promotion depends on a population-based strategy of prevention. So the foundations for lifelong health are set in childhood. Childhood poverty casts a long shadow. It's an underlying determinant of ill health. And the research on health inequities are frequently shown with those with poor levels of education experience poorer health, as determined by those graphs earlier. And when we look at health disparities in general, it is a higher burden of illness, injury, or disability experienced by ethnic groups, those with religion, socioeconomic status, gender identity, mental health, cognitive, sensory, physical disabilities, sexual orientation, geographic location differences. Here are some really important differences. Health disparities are the differences in the incidence and prevalence of health conditions. Inequities are systematic, and as a macro social worker, that's what we work on. It's an unjust distribution of social, economic, and environmental conditions. And health equity really focuses on the opportunity for everyone to attain his or her health potential. And the social determinants are life-enhancing resources whose distribution across population determine the quality of life. So when we look at how these all play together, we have health, environment, and equity, and they are connected by education and work and community and transportation and what our community looks like. Healthy individuals create healthy communities. And how do we do this work, right? This is a lot of work to do. And how do we go about doing it? So we need a place-based approach. We need to look at social determinants over the course of a life. Prioritize five key determinants and their associated factors. Look at each determinant and how it interacts with the other four. Don't work in silos. And look at all of the effects of the health of an individual. And again, we focus on neighborhoods, education, economic stability, health and healthcare, and social and community contexts. And we address these things because they're important, because if you want to solve a problem, you have to look at the root causes. You have to look at the root causes so you look at a short-term and a long-term approach. And it's easier to approach this issue and its underlying factors rather than deal with it directly. And addressing the social determinants presents a tremendous opportunity for learning. Everybody gets to address the social determinants in community health. But we also need to remember those affected by the social determinants of health and poor health outcomes need to be part of the conversation. You know, there's that saying that you don't do anything for me without me. We have to make sure that everyone's voice is at the table. And then we need leadership, kicking and screaming or coming willingly to decide how they're going to address these issues of inequity and disparities. And we also need everybody to understand that it's going to be a change, a sacrifice, but we all need them to take action in moving in the same direction and choosing anyone else who's at stake, including our business communities. And when do we do it? We kind of have to do it now. We have to do it when we're looking for fundamental change. We need to do it when we're advocating for laws and policies and when our focus is on community wellness and prevention. Because great ideas don't just unfurl, they must be sought out, not just thought out, but brought out of the best of ourselves. And that is from Amanda Gorman, who was the rock star of yesterday. And now back to you.
Thank you so much. And that was now 2 days ago, but she is a rock star indeed. Michelle, thank you really for all of that information. I know that every single time I hear it, I hear something new, and it is really exciting to be able to provide that information to everyone on the call as well. Folks want to know if you would be willing to share the PowerPoint.
For a small fee, yes, we're a not-for-profit. And I'm totally kidding.
Wonderful.
Absolutely. I will make it available to everybody.
Wonderful. So if you can just send it to me, I'll send it out with the surveys this afternoon.
Perfect.
Great. Thank you so much. All right, wonderful. So now moving on to the panelist portion of our program today. It is really my honor and privilege to introduce, in addition to Michelle, our other two panelists. We have with us Linda Muller, who is the CEO and president of Cornerstone Family Healthcare. And we also have Giovanna Rogo, who is the executive director of Maternal Infant Services Network, MISN. So welcome, ladies. So we are going to start with, what I like to consider a simple question. Michelle really laid the foundation for us, explaining what health disparities are, but I'd like to bring it back home. Can you, the three of you, in your words, tell us a little bit about what you're experiencing? What do health disparities and inequity look like here in Orange County? So in our local community, what are you all seeing? Are you able to unmute yourself, ladies?
Yeah, I think Linda's on mute.
I think
Linda, we can't hear you.
There we go.
go.
Now I can
Okay.
unmute.
There we go.
All right. So Giovanna, do you want to go?
Sure, I'll go. So I am, MISN, as you know, supports moms, children, youth, and families as a whole. So thank you, Michelle, for the wonderful presentation that you did. I'm going to speak from a woman's perspective, from what we see in our agency. And we provide healthcare insurance. We register families for healthcare insurance. And that's really important because not having healthcare insurance during a pandemic, and if you're undocumented as well, really is catastrophic. It is catastrophic, not only for you, but also prevents for the healthcare of the family. And so that is something that we see a lot of. And as a mother, that is, it affects your mental health, your family health, your everything. So I'm not going to talk about, I'll talk about the other social determinants of health in a minute. But in September, in our country, 4 times as many women lost their jobs as men did. And that's probably consistent throughout the entire nation, including Orange County. That's really important because when mothers don't have jobs, that means that there's food insecurity, housing insecurity, that they can't even pay the cable, and this is really important, pay the cable bill for the necessary Wi-Fi for their children to be able to do their school lessons, right? And so there's a huge impact, not only in Orange County, I'm sure the entire country, but in Orange County, we go across 5 counties. It's been consistent where women just really have bear the impact of a heavy impact of this pandemic. I can talk about that for a long time, but I'm holding myself back.
So, if we're looking at the question of healthcare disparities in Orange County, I think that the same disparities that we see across the country. Cornerstone Family Healthcare is a federally qualified health center and have been proud to hold up the firm beliefs that healthcare is a right and not a privilege for all people, period, no other further explanation. When you look at the disparities within our communities as reflected, whether you're in Alabama, Mississippi, New York, California, it is never a good place to be poor. It is never a good place to not speak English. It is never a good place to have a communicable disease. You are looked at as being something less than. And it is reflected throughout all of the segments of the healthcare industry. When Blue Cross and Blue Shield went from a not-for-profit organization to a for-profit organization, it just kind of tells you what happened. No longer was it important to think about who your shareholders, your stakeholders were. It moved to your shareholders. And you hear this throughout the nation about for-profit healthcare versus not-for-profit healthcare. So if you're poor, where do you go? Traditionally, you went in New York State to a hospital because of the corporate practice of medicine. For a hospital or an Article 28 like we are, you can't be a for-profit. We are based in public health, and we're based in an understanding that no patient ever gets turned away because of their inability to pay. So if you went to the hospital, you went to the emergency department, and you went to the emergency department for a sore throat. Well, is that the best place to get your care? It is the most expensive portal in the healthcare delivery system with a lack of comprehensive care. So FQHCs came around in 1965 in areas where there was high poverty, low access to care. We got our start in 1967. And so what is it that we try to do? Well, we try to decongest the emergency department. Folks shouldn't go there. They should come to us. They should come to our urgent care center. They should develop a relationship with their provider of care. And if you can do all those things really well, you can actually change the trajectory of illness as it is on a population. Just for a moment, think about Orange County. Can you get from Newburgh to Goshen really easy? No. Can you get from Middletown to Port Jervis really easy? No. So transportation to get to the doctor's office is really hard. Think about it for a person who's living in the city of Newburgh. Do they have a car? Probably not. Do they have excess money sitting around to get a taxi? Probably not. So how do you address these concerns? And what if you go to a provider that wants to know where your insurance card is even before you walk in the door, or tells you that you can't be seen unless you've got your copay, or if you don't have insurance, you've got to pay the full barrel? Are you going to go to that doctor? Probably not. So you're an undocumented worker, and you're living in any of our communities where we understand that all children under federal law can access health insurance under the S-CHIP program. That seems easy, like a no-brainer, right? But it requires family members to come outside of the darkness to come in and apply for a program where they're frightened to be deported. We send mixed signals all the time. We say we know we have health disparities, and we know people of color, and we know communities that have been disenfranchised for years need help. Yet do we provide those services and that help? Not unless you've got an FQHC sitting in your community. Probably not. Health disparities are things that I would like to think that we don't do purposely, that we do it because we're just not smart enough to understand that if you can treat an illness before it becomes a problem, you can not only save money to the system of care, but you save a life. If you can engage a patient and find a stage 1 breast cancer until you found a stage 4 that's metastasized, you've saved money and a life. If you get a woman into care in her first trimester, instead of showing up at the emergency department without prenatal care, you've saved a life or 2. So we just need to figure out what the priorities that we think about healthcare. And that doesn't take me or Inaudi or any of us, Giovanna or Michelle. It takes a country to make a decision about what healthcare should look like, how it should be delivered, and what people should expect from their providers of care.
Linda, I want to put a hold right there because
Sure.
you're going into a thought of another question that I'd like to ask. But
Sure.
first, Michelle, did you want to add something
Well,
to
and
what
I
we're
think,
seeing locally?
yeah, and I think to Linda's point, we really have to be intentional in our in our work, right? If we know that there are health disparities, how are we choosing to address them? How are we making a conscious outreach to those marginalized, underserved communities? And are we doing it? You know, if we look at our own staffs, if we look at our own organizations, our organizations set up to be convenient for the people who work there, the people who they serve, right? So if we are looking at transportation, childcare, preventative health as having long-standing disparities, what is the ability to address those, and how have we not addressed those as a system? Not that individual organizations haven't, but I think as a group, we have to have a difficult conversation about what we are deeming as important and valuable, and who is important and valuable. If we look at vaccine rollouts in our community and others, who are getting vaccines and who are being left behind? And if we're not willing to have those difficult conversations, I think it's going to be harder as we move forward.
Wonderful. Thank you so much for that. And again, it really leads me to my next question, which I think you and Linda really did a nice job in kind of segueing into it. What are some of the challenges? If we can just briefly talk about what are some of the challenges into addressing these disparities, right? Because, you know, if anyone who's on the call with us has attended any other of our forums, whether it's hosted by the Human Rights Commission or RECAP or Health, the Cornerstone, or any of the partners, this is something we continuously talk about. This is something that is always at our radar, and that in our community we know we have. Giovanna, later on you'll share a little bit about, because I'll ask, what are we doing to address it? But before we get to the positive and what are we doing, what are some of the challenges that we are facing in order to be able to meet these challenges head on and face them and get through them?
So the connection between resources and communities becomes difficult. Is there enough to go around for everybody? We'll just 2 seconds on COVID. COVID negative outcomes were much higher in Black and brown communities than they were in white communities. Why was that? Vaccinations for COVID-19 are more prevalent in white communities than they are in communities of color. So a lot of it's about resources. A lot of it's about trust and connections between multiple groups to make sure that patients get what they need when they need it. And a lot of it's got to do with just changing the mindset of community residents about where should they go for their healthcare. We still have people who will choose to go to the emergency department before they would come to their primary care provider. I can't explain to you why that happens. I'm happy that people have accepted our health center as something more than just the health center for poor people. We're the health center for all people. That in itself speaks to something closer to equity within our communities. But if we don't have the resources to be able to make a change in the communities that we serve, we can't make the change in the communities that we serve. And traditionally, Black and brown communities that have been disenfranchised, are not given the tools necessary to effectuate the change for all community residents, maybe just for some.
Thank you. Giovanna or Michelle, do you want to add something to that? Some of the challenges that you find in addressing these inequities? Giovanna, you're on mute.
Okay, I think you had to unmute me. Yeah. Okay, so we're a small community-based organization, and for us, funding is always an issue. This year, just like Linda just said, having the resources at the same levels that we've had in the past to provide the services was impacted by COVID-19 this year in New York. So that's a huge thing. But I also wanted to speak to the subject of relationship. I think that one of the reasons Cornerstone is so successful in Newburgh is because of the length of time that it's been here and established trusting relationships within the community, right? And I think that trust in relation to vaccinations is a huge issue due to the experiments done on Black people in the past and the historic past. So there are a lot of paradigms that need to be overcome. And yeah, I mean, having the resources when you're a community-based organization to provide the services is always a challenge.
Yeah, and I think, you know, those challenges are fluid, right? So when, you know, we think that housing is the primary need, and then you hit a global pandemic and you realize that there is a lot of hungry people in your communities, right? So if you don't have access to basic needs, you know, there's the triangle of basic necessities. If you're not hitting the foundational ones, you're never going to be able to get to optimal health. So, you know, I think that as we are all attending to so many needs, you know, we hit roadblocks, you know, and I'm a macro social worker, as I said, and if we don't have a systematic approach to food insecurity or housing stock or transportation or childcare, we're really going to stay stuck where we are. You know, feeding an individual is great, but making sure there's enough affordable, healthy, accessible food in a community is better. And we have to stop putting Band-Aids on bullet holes and start making real strides to fix systematic problems that exist in all of our communities. And we have to do those sooner rather than later.
One of the
Wonderful.
biggest
Thank you so much.
one of the biggest issues is healthcare is usually is everybody's last concern, right? You need a house or a home or a roof, you need food, you need a bunch of stuff. You don't need healthcare until you need healthcare. So you don't think about it. Our nation has trained physicians to treat illness, not to promote wellness. And so when you're starting to think about how do people access their care, they access it at the wrong time when they're sick. And then you have to think about, do you have the money to go to the doctor? Do you have the money to go to the pharmacy? Do you have the money to take care of what needs to be taken care of? And so I just want to dispel one fact that people think. If you are an undocumented worker in this country, you are not eligible for Medicaid. You're not eligible. It's plain and simple. You just aren't allowed to get it. And if you were allowed to get it, you know what? You're probably not going to get it because you don't want to get deported. So you have this whole segment of the population who are poor to begin with as migrant or transient workers who don't have a lot of excess resources. And how do they get to the doctor to start with? So we've got our priorities all screwed up. You know, to take your child, you got to take the child, 2 or 3 times a year. You got to get the child vaccinations and make sure that they're meeting all their milestones, and women should be getting their pap smears, and women over the age of 40 should having a baseline mammography. And, we go to the dentist twice a year, all the things that we need to do. But if you're not in a place where you can afford to do that, you don't. And we need to do a dynamic shift about putting one's healthcare priorities high enough to want to make sure that disparity between the death of a 74-year-old in Newburgh and the death of a Warwick resident at 84, that's controllable with the right resources.
It is, and just to kind of hammer that home, being poor is expensive, right? So there's a great graph that I saw yesterday that was, if you ignore a toothache, it becomes a root canal. If you ignore, a small lump in your breast, it becomes breast cancer. If you have an open wound because you may be struggling with your glucose levels, it becomes diabetes and an amputation, right? So all of those things are expensive. They're expensive money-wise, but they're also expensive at the expense of your health down the road. So figuring out prevention is always better than reaction, and we have to do so much better on prevention in so many ways.
I wanted to
Wonderful.
add
Thank
to
you
that
so much.
thought. I wanted
Go
to
ahead,
add
Giovanna.
I wanted to add to that thought because while I appreciate, the macro level of what it is that we're discussing, in our agency, we experienced a lot of moms that couldn't get Pampers. And couldn't afford Pampers. And sometimes, on the individual level, it's and we had to figure out how to get emergency supplies like baby wipes and Pampers and formula, because if you were a pregnant mom or a mom that had just given birth and was breastfeeding, the stress of it all affects, your breastfeeding capacity. And so, I just want to introduce another aspect of all of this and just really challenge that on an individual level. We really have to redefine our involvement and our place where all of this is happening, because we can get so minded that we think, oh, someone is doing it, or an agency is taking care of that, or, and really, I think that the time has arrived in our country where we need to show up on an individual level to speak ourselves related to our healthcare, our housing, at whatever stage we are at, and economics doesn't really define that. And we saw that in this country when people just went out to the streets and said, there is injustice happening. I think the time has arrived for the communities, for individuals to show up and speak to the communal destiny.
Giovanna, that is the perfect segue to my final question. How do we show up? But before I ask you all, I just want to make sure that participants know this is the time where we're asking you if you have any questions for any one of our panelists around the topic. Please enter it into the chat box now, because now is when we will address some of those questions. We won't get to all of them, but we do promise that we will share the panelists' contact information. So how do community members show up? If one or two of you can kind of ask or answer the question very briefly so we can have time to hear from participants, what can community members do to help address these inequities to both healthcare and health overall? How do they show up?
I'll go. So we have created, out of MISN, we undergird the Black Maternal Health Coalition, which is community-led by moms within the community, and men too are part of that coalition. It meets the second Monday of every month at 2:00, and you can email me if you want more information. But that coalition brings together Black and Brown moms and is to be empowered. It consists of embracing not only the cultural lineages, but it provides resources and productive content in engaging interactive communication between Black and Brown women. And why is it the Black Maternal Health Coalition? You may be asking. And that's because the research clearly shows that Black women are 4 times greater, not at risk of dying, but actually dying compared to our white sisters in the United States. And in New York State specifically, they're at 12 times greater risk of dying than our white sisters. That is something that I feel so strongly about that coalition because it's community-led, and we empower that coalition to definitely go forward. One of the other things that MISN created is we created a Women's Forum podcast, and the podcast comes out every 2 weeks, and it's so I'm so incredibly proud of the women that talk about that, that put on our podcast, the interviewers that come on board, and because everything is virtual now, right? And you don't even commute. I used to listen to things on the radio on my commute to work, right, on the car, but now we don't commute, we're at home. So everything is virtual. We put out the podcast as a form of conversation and education to talk about things that are taboo and that are not traditionally talked about in the Black and Brown communities, such as mental illness. and what to do about that, and destigmatizing that, because during this time, these are really stressful times. You've seen increase in domestic violence and substance use and in mental, just mental challenges. So that podcast, we did that. Of course, we have the Navigator program that actually registers people for healthcare. And there is a program that provides healthcare insurance also for undocumented women and their children for a limited time. And because that's important, like both Michelle and Linda have mentioned over and over again, healthcare is, if you don't have insurance, and if you have no way of insurance, and if you don't have the money, it just really is devastating to a family. And then our community collaborations. We have strong community collaborations because no agency that's included on this call right now is able to do it on their own, as we all know. And lastly,
Yeah.
I'll
Giovanna,
just say,
Giovanna, I don't want to. Sorry, I don't want to stop you. I just want to make sure that. Sorry.
Okay. The individual.
Yes. So if Michelle or Linda can take a quick second to give us some quick tips as to how can community members get involved in addressing inequity.
I'll jump in because Linda is a fantastic closer. So I will just, to Giovanna's point about individual, it's making sure that we're all taking care of one another. So we, back in March, created Newburgh Mutual Aid with other partners in the community. And it's about showing up for each other. So since then, with a whole bunch of other groups that are doing this in the city, but we have been 2 days a week making sure that people get fed. With nutritious food boxes. We at a High Point we're delivering about 550 a week to the city of Newburgh and beyond, and we are still having about 200 to 250 go out every single week. So while some of that is pandemic related, much more of it is about food inequity. And individually, what we can do is start addressing those needs systematically. And one of the things that Recap is doing with our food pantries is creating a special needs food pantry, which anybody with high blood pressure, heart disease, or diabetes can come in and get foods that match those types of diets to create some health balance in their life. So, that's something that we're really excited to be able to do in this upcoming year.
Thank you.
So kind of just on the ground, what can we do? So let me just give you a real quick overview of what the world kind of looks like in our community. We've been out in community doing COVID testing for a long time. And people came up to us who were not our traditional patients, and comments like, "Oh, wow, you guys are nice. Oh, you guys know what you're doing. Oh, you mean we could come and get our care there?" And then we got 1,700 doses of vaccine on December 22nd that were slated for 1As. And then the governor allowed for 1Bs to open up. And people who would never have thought to walk into my health center walked in to get their vaccine. And it was like, "Oh, this is a nice building. Oh, you've got really good providers." The perception is if you treat poor people or communities of color, then you've got to be substandard, because who in the name of all that's almighty would you want to work in a place to take care of poor people? Don't you want to go make more money and work in communities where there's money? And that's what we need to change as a community. So I couldn't be any more proud of my staff who welcomed folks who, I don't know whether they'll ever show back up again. Hopefully they'll come in for their second vaccine. But they got to see for a moment that what they thought was normal in a poor community did not meet their expectations. In fact, we exceeded their expectations of what they receive at their doctor's offices. And that in itself is what we should be talking about.
And just two other groups of people who are often left out of these conversations are people with accessibility issues, if they are in wheelchair, or other of those, are the services is provided accessible to everyone? And, do we know a service is safe for somebody who has status issues? And I think we need to be really clear in the services provided, not just from us, but across the board, that we are making sure that our services are accessible. And when we say accessible, we mean it to everybody. Wonderful. Thank you so much. So we do have a couple of questions. If maybe one of you can answer, because we want to be able to get through a few of them. The first question is around the mistrust of the healthcare system because of systemic racism amongst Black and Brown folks. How do we get through that? How do we get through the barrier of mistrust because of the systemic racism and, everything we know about why there is no trust amongst the community? If one of you can kind of tackle that on.
Well, I think one of the biggest things is, first of all, if you're going to provide services in a clinical setting, you need to look like the people that you serve. You need to speak the language that the folks who come in your facility speak. You need to be more than a medical record number. You need to be a person. And when practices are looking simply at the end result of, yeah, I'm not saying that doctors don't care about good outcomes, but they also care about what's in their pocketbook when you're a solo practitioner or you work for a large group practice that's for profit or ownership driven. You need to figure out what internal barriers that you have put up that causes distrust for the community. There's if you're a Medicaid patient and you come in and you need surgery, maybe that practice doesn't want to take care of you because the reimbursement rate on a Medicaid surgical procedure is not good. And they'll tell you, we don't want to, we can't do that for you. The trust has got to be about how do you deliver services? What do people look like who deliver that service? And there's just two words. Is there respect and dignity provided to all people, period? And if we can get there, then it can be better. I can only speak that I know that there's a high level of trust between us and our patients because we've never given them a reason not to trust us.
Wonderful. Thank you so much. Another question that we have from our participants is addressing the present issues of disparities is valid. What are the prevention measures in place for grassroots education? Equity Health does not create action without infusing into grassroots community. So are there any prevention measures in place around grassroots education on these issues? Michelle or Giovanna, do you want to take this one? I thought Giovanna was talking.
I'm not really, I think that we have to have more space to have the challenging conversations. We talk about the issues a lot, and the issues are real. And I think that sometimes that there's not enough space, or we don't talk about we don't have the difficult conversations enough where we learn about each other, and starting at the smallest denominator, because yeah, they're real, and they're obviously unconscious, and there's obvious systemic bias and individual bias. But if we don't talk about it, we can never get to solving the bigger problems.
Yeah, and I think part of the solution includes, in answering the question of what can community members do, it's starting that conversation. It's holding elected officials accountable. It's holding our employers accountable. It's holding our doctors' offices, the leaders of the community accountable in having these conversations, so that there could be many more of them. Agreed.
Yeah, it's showing up.
It's showing up, yeah. And creating community around that, right? Because I feel like grassroots is all about creating that community. I want to point out that in the chat, there's a lot of really wonderful conversations going on and a lot of really great comments. Folks have talked about, needing more mental health services for speakers other than English, right? So whether it's Spanish speaking or other languages, that is definitely a big need in our community. I also want to point out Doug Hubby, who is the president and CEO. Thank you, Doug, for being here, of Independent Living, and also a human rights commissioner. He's adding a lot of really wonderful points to the conversation of the lack of access, right, to healthcare. And, the challenges and for the different groups, right? So there's a lot of different groups, but I want to point out, something in his comments specifically talks about treatment exam tables have to be accessible for people with mobility impairment, right? If I can't get on the table, I can't get an x-ray or an exam. Our service is accessible for people who are deaf, blind, or have cognitive and developmental disability. So when it comes to challenges, access to it is definitely one of the biggest challenges that we have. So would any of you like to, so not would any of you, for closing, I'd like you all to take a quick minute. And again, to all the participants, we will be sharing the video recording. We will be sharing the PowerPoint and the contact information. But I'd just like to give each one of you 1 minute to close. If you would like to leave us with any message, whether it's something that you're doing within the community and you'd like to share, or it's just something to leave us with before we close.
I think for me, everyone's talked about showing up, and I think that's really important. Having the difficult conversations. It's never difficult to talk about inequity and disparity, and I think we need to have those conversations more often so that people are more comfortable having them and recognizing their own, sometimes unconscious bias. For us, for tonight, in terms of kind of showing up, we're doing the annual point in time count tonight. And we will have teams of folks in the city of Newburgh looking for those who may identify as houseless. So if anybody wants to do that with us, we are at 201 Broadway starting at 6, and we will be in the city throughout the night, because our message to our community is that everybody counts. And whether you are the CEO or the COO of an organization, or you are somebody who is struggling with addiction or mental health or houselessness or food security, we want to make sure that you have value and that you are treated with dignity and respect and that you count in our community.
Thank you, Giovanna. Would you like to leave us with something?
Yes, I just wanted to add to what Michelle is saying. My thought on that, it is so right on. It's like, have the conversation, because you are not alone. We're never alone. I felt so heavy over the last 2 weeks, and I had the courage to ask someone, are you feeling heavy too? And I realized I was not alone. A lot of people were feeling the same way. And so no matter what it is, whether it's a law, a policy, a practice, it starts with one person that speaks with another person and realizes they are not alone. And I'll leave everyone with that from my perspective, because it really does start with one.
Thank you, Linda.
So if any of you have ever gotten an email from me, I have something that's written underneath my signature line, and it says, of all the forms of inequity, injustice in healthcare is the most shocking and inhumane. And that was written by Dr. Martin Luther King. At the end of the day, we have to make decisions about how healthcare should be delivered and received, ensuring that all people are welcomed into their physician's office is imperative. Never judging what you think a person is like because of their circumstances is something we should never do. All people, regardless of their situation, should be welcomed into a practice of medicine, because we are really the only group of people in our community that hold the life of a person in our hand. We either have a good experience where someone comes back and lets their condition be treated, or we create a barrier where someone chooses because they feel unwelcome to walk through the door. And the healthcare providers working in community with like-minded people, and even those who aren't quite so like-minded, but we can change the direction of their thinking. If we can make everyone understand that healthcare is about a life, it's not about a widget, it's not about a piece of paper or a car, it's about a life. It could be yours, it could be somebody you love, it could be your neighbor, it could be anyone, and failure to be able to provide equity in healthcare delivery is one that, as Dr. Martin Luther King said, cannot, should not be tolerated.
Thank you so much, Linda. There is a reason you are our closer, for sure.
Told you.
So, yeah. Again, I just wanted to a very special thank you to our panelists for taking the time to sharing all this wonderful information. Also, a very special thank you for everyone who attended today and joined us during their lunch hour. On the screen, hopefully you were all able to see our contact information. Please feel free to take a picture of it and you will have it. I will also be sharing it via email. Please take a second to fill out the survey that I send out because it is really useful information. And finally, a very special thank you to our partners, the Junior League of Orange County, because, really, it is a wonderful opportunity to get to share this space and platform with you all, but for all the work that you ladies do in making sure that important conversations are taking place in our community. With that said, thank you everyone for being here and have a wonderful rest of the afternoon and a wonderful weekend.
Bye, everybody. Happy Friday.
Have a good
Happy
weekend. Bye.
Wear your mask.
Have a good weekend.
Wash your
Bye-bye.
hands. Keep 6 feet of distance, please. The pandemic is still out there.
Yes.
Thank you, Michelle. Thank you, Giovanna.
Bye, guys.